Okay, so I'd like to welcome everyone thank you so much for joining us today for our Cultural Competency in Healthcare seminar today. So first, I'd like to start by introducing myself. My name is Maram Khairan, and I'm the president of the Fresno State chapter of Friends of MSF, or MSF is an acronym for Médecins Sans Frontières, which is French for Doctors Without Borders. Our student chapter officers who are present at this moment, Charles and Gurney, if you guys can introduce yourselves before I introduce the chapter.
Hello, my name is Charles and I'm the vice president of this club.
Hi everyone, my name is Gurney and I'm the treasurer of this club.
Awesome, and we'll have our publicity and campaigns officer and our secretary joining us shortly. So I would like to first, before we get ahead and start with our seminar, introduce our chapter. So you just met our officers, and we are actually the first student chapter representing Doctors Without Borders in the Central Valley. And our goal was to first engage our community with MSF's work and to promote its various campaigns. So that includes first their health equity advocacy campaigns, which are both global and local to the United States. Volunteer locally with underserved communities to help minimize the healthcare gap in the Central Valley. And you guys, if you guys are interested in that, you guys can head to our Instagram where we post volunteer opportunities and where we serve as verifiers for your hours. And third, to raise awareness and knowledge about humanitarian issues. So this is medical and non-medical. And to encourage students to consider working with non-governmental organizations and humanitarian organizations such as MSF after graduation. And lastly, to fundraise for MSF's global healthcare work, since of course money is a big role in how many services they can provide. So without further ado, I'd like to introduce our speakers today. I'd like to thank Donna Canali, veteran nurse and medical coordinator for Doctors Without Borders, for joining us today from San Francisco. And Dr. Andrew Fiala, who is our very own professor of philosophy and executive director of Fresno State's Ethics Center. So please give them a warm welcome, and we can go ahead and get started with Dr. Fiala's talk today.
Yeah, Madam, thank you very much. And how great that the students took the lead on putting this together. So congratulations to you and all the folks in the club for putting this together. It's a busy time of year, so, and I'm thankful for all the students who showed up. So I'm going to talk briefly about cultural competence and compassion. So I'm going to share my screen, and I promise only 10 minutes because we want to hear from our visiting expert who is working directly with Doctors Without Borders. Let me see if this works. You can see my slideshow?
Yes.
Yeah. So just to frame the issue from my vantage point, I'm an ethics professor. I've taught courses in bioethics. I've taught sections on bioethics and healthcare ethics in my problems in ethics courses. There are these commonly accepted principles of healthcare ethics and biomedical ethics: non-maleficence, beneficence, utility, distributive justice, and autonomy. So, I mean, variations thereof, those 4 or 5 values are often discussed and cited in the bioethics literature. Non-maleficence means not hurting anybody, do no harm, kind of first principle. Beneficence means helping and healing, which is obviously what healthcare is all about. And then utility has to do with maximizing good outcomes for groups of people. Justice is about fairness, making sure that people are treated equitably. And then autonomy is respect for consent, respect for the liberty and consent of the patient. What's fascinating to me, as I've been teaching this over the last, 10 or 15 years, the word compassion really doesn't show up in healthcare ethics, which is very strange. And I could give you a much longer story about that, but one of the reasons is that in the Western ethics paradigm, it's much more about rights and producing outcomes. And it's not about the kind of softer side of healthcare, which we call compassion. There's other words there we could use. And we even talk about these as caring professions, but the ethicists very rarely talk about compassion and care. So that's fascinating. I've been thinking about this as I'm revising my ethics textbook about how can we incorporate some of this stuff, especially compassion. And then this other phrase that we're here to talk about tonight, cultural competence, also in the leading textbooks on healthcare ethics, biomedical ethics, cultural competence is really given hardly any space. I mean, it might be like a footnote somewhere. It's not important, although it's growing in importance. And I'll give you a reason why it needs to grow in importance in just a second. Compassion, what do we mean by that? Well, that is emotional awareness. It's feeling with someone who's suffering. Now, there's a problem, obviously, and maybe our nurse visiting healthcare expert can explain some of this, but there can be kind of compassion overload, right? Like it's at some point, maybe compassion intrudes on the well-being of the caregiver and, can impede judgment and so on. Nonetheless, seems like it's very important. Cultural competence, I mean, basically that's understanding where other people are coming from in terms of their cultural background. These things obviously important. So I've taught a whole class on compassion. There's a lot to think about with regard to the word compassion. And it's more complicated than we think, right? It's not just this kind of soft openness to others. It can involve joy, right? Compassion is involved when we share joy with others. And there's sometimes a worry that compassion is too oriented towards suffering. And I think we need to think carefully about that. What exactly is compassion? How does it work? Where's the focal point? And let me just jump towards the end of the slide here, third from the bottom. When you read the literature of people talking about compassion, it's really an art. It's a way of being in the world. It's a kind of spiritual practice, right? It's an orientation. And there's no rule of thumb for this. And people learn as they go. And sometimes we make mistakes. But it's different. The challenge of compassion is different from the challenge of thinking about justice or respecting the autonomy of patients or distributing harms and benefits across populations. Compassion is different. And I think it's connected to cultural competence, as I'll explain in just a minute. So here's a couple of quotes to frame this. Martha Nussbaum is a well-known ethicist at the University of Chicago. She says, compassion is a painful emotion occasioned by the awareness of another person's undeserved misfortune. There's a lot more to be said. We could really spend some time unpacking that. But notice that the person who is suffering, who we identify with, their suffering is undeserved. So there's a whole framework and discourse thinking about what kind of suffering is deserved and what kind of suffering is undeserved, which also have cultural implications, right? And different cultures will explain this and interpret it in different ways. And then let me introduce you to Thupten Jinpa, who is a Buddhist. He's actually a student of the Dalai Lama's, and he works at Stanford. And he's on there's like a compassion project down at Stanford, and he's the director of the compassion project. And he says, at its core, compassion is a response to the inevitable reality of our human condition, our experience of pain and suffering. And if you know anything about Buddhism, the first noble truth is that life is suffering. And so Buddhism begins with this awareness of the importance of suffering, with this suggestion that we do better when we share our suffering. Okay, so one other topic that's connected to and easily confused with compassion is empathy. It turns out actually in the literature, people use these words in sometimes synonymous ways, and it depends sort of how you define them. But one issue that's worth considering is that empathy is morally neutral. Empathy is literally just a psychological ability to experience, to sort of put yourself into what someone else is going through. But it can be cold. It can be dispassionate. You can understand what someone's going through without actually feeling what they're going through or leaping into their frame of reference. And in healthcare, I'm sure there's an open question about whether we only want to be empathetic or whether we also want to be compassionate and how that fleshes itself out. The difference I propose is that compassion is not neutral. not just a psychological ability, but a morally engaged orientation towards the suffering of the other person, a kind of active orientation. And the word that's used with compassion often is warm, as opposed to empathy, which is cool. Now, both of these things are obviously important and psychologically interesting. But again, in the literature, in the bioethics literature, there is a focus on empathy, but not so much a focus on compassion. There may be a reason for that. We could think about that, but just to put that in your brains as you're reflecting on this this discussion this evening. Now, I'm not going to read this to you. This is a case study that we created in the next edition of my ethics textbook. But it's a pretty famous and interesting example to kind of get us thinking about the importance of compassion and cultural competence. And it's local. So you may, some students out there, you may have heard about or run across this book, The Spirit Catches You and You Fall Down, which is a story about a child in Merced, California, who was a Hmong child from a Hmong family who had escaped from Thailand and made their way to California. She had epilepsy, this child, and the family understood her ailment as a spiritual ailment, that there was, some kind of issue going on with regard to spirits. It's very complicated and very interesting. If you're interested in Hmong culture, I recommend this book. It's fascinating to read about sort of the beliefs of our Hmong friends who live here in the Central Valley. We know these people. They're our students and colleagues. Anyway, the story is tragic because what happened is that the healthcare professionals really insisted on treating this as a neurological disorder. And so they insisted on treating it with medications, and the family, who also had linguistic issues and cultural issues, the family didn't understand all of the treatments that were being used on their child. And unfortunately, the child died eventually. And this now, Ann Fadiman wrote this book now like 20 years ago. This case study, this example has been used in folks in healthcare ethics. And we've had the good fortune to talk about it in a couple of different places at Fresno State. So again, frame this now. One question here is about compassion. I believe when you read this book and look at it and think about the case, the doctors did have compassion. So they were concerned about the child. And when she interviewed the doctors were really disheartened when the treatments didn't work, and when the child passed away, it was traumatic, right? They were not happy to have this happen. But these doctors, again, 25 years ago, and I think healthcare professionals are much better at this now, these doctors lacked what we might call cultural competence. They did not understand Hmong culture. There was even like systematic problems, like translation issues, and working with folks in the community who can help support what was going on. And again, a tragic case. And the takeaway has been, and it's not only this case, there's lots of other cases, and we'll probably hear about some other cases, but the takeaway has been that healthcare professionals need to develop cultural competence in addition to those ethical principles I talked about at the beginning, right? It's important to understand, it's somehow connected to autonomy and consent. It's kind of connected to beneficence, but really the focal point here is that patients, families, people that need care come to the world from different places. And it's important to understand where they're coming from and put oneself into their worldview, in a sense. And really, it's like a tool to produce better outcomes, right? When one can understand what the patient and the family is going through, then it'll be easier to produce better healthcare outcomes. So I'm not going to go into these questions. I had them there just in case. So let me conclude my brief remarks here. So compassion, I think, is important and often overlooked in the healthcare profession, although I think that might be changing. And then cultural competence is new, like in the last 25 years since that case of the Hmong child in Merced, California. So here's some skills and values that are probably essential for thinking about the tool, the idea of cultural competence. First is knowledge, right? One has to understand the other. And this includes, as you may have heard this phrase, intersectional identity, understanding the intersectionality of our identities, that we come from different places, and it has to do with gender, class, age, education, linguistic ability, et cetera, geographic location, and obviously culture and religion factor in. So we need to know more about the world and the people we're interacting with. And in healthcare, we need to know more about the people that need our help. And then, of course, self-knowledge. So self-knowledge is about understanding our own biases, our own presuppositions, understanding our own blind spots, right? Taking a look in the mirror. Then, so what do? Well, we need to listen more carefully. That case of the spirit catches you and you fall down, one of the obvious outcomes was that those doctors needed to listen better to the family and understand what their concerns were and where they were coming from. Active listening, not just, making a space, but then not paying attention. It's sort of like leaning in and actually listening. Of course, values. So, respect for autonomy, the concern for beneficence, non-maleficence, all these issues that I talked about earlier. And then these two values, toleration and hospitality, kind of work hand in hand. Toleration, just let me point out, is sometimes kind of cold and negative. So when we tolerate people, we just allow them to be who they are, right? That one of my students today said, let you be you, right? We just sort of, it's a hands-off thing, toleration. Hospitality is warmer. Hospitality is not hands-off, it's hands-on, right? It's reaching out and bringing people in and welcoming people to the conversation. That's an important part of this. And then finally, I would argue that compassion seems to be an obvious component of this. So back to a definition of compassion, right? It is warm-hearted regard for the well-being of the other. It's the ability to feel with people who are suffering. And that's clearly got to be part of the conversation of cultural competence. Okay, so I'm going to stop my screen share if I can. And that's my contribution. Maram, back over to you.
Thank you, Dr. Fiala. Does anybody have any questions before we move on? So you can unmute right now or put in the chat and I can ask Dr. Fiala. Okay. So in the meantime, if anybody will wait for that in the chat. But first, I wanted to thank Dr. Fiala for such an awesome talk. 10 minutes is not even enough, just the tip of the iceberg. This is like a topic very dear to my heart, cultural competency in healthcare, because I feel Central Valley is so diverse, but our healthcare, our health force, or people that are serving us are very knowledgeable, but maybe not knowledgeable about our backgrounds or our culture or everybody else's culture, So many people here from all over the world. And so that's just something very, very dear to my heart. And I love this. Even Dr. Fiala's every little word on his slide can go into books and books and books. So very depth, very deep. And I encourage you all to look into this more. It's such a different world, right? Anyway, that's something I really, really like to learn about more. But in the meantime, no questions I see in the chat. So if you guys get any questions, just feel free to put them in the chat. But I'd like to put the floor for Donna to go ahead and share with us your experiences with MSF and your opinions on cultural competency in healthcare.
Okay, well, thank you very much. And there was so much in that presentation, Andrew, that I'm sure I could come up with many questions, but I can't because then my brain would get all muddled. So anyway, I'll go on to my presentation. And let me see if I can share the screen here. And then I will, let's see here. So I was asked, can everybody hear me okay? Mm-hmm. Okay. I was asked to say, how did I get involved with MSF? So just briefly, some years before I got involved with MSF, I did volunteer work in Latin America, primarily in Central America, both solidarity work and volunteer work, from things to healthcare to picking cotton to building houses and whatever. And I love doing that type of work. later on, I've been an activist for a long time, so I was involved in different things. Later on, I realized, I want to get involved in international work again, and I explored different avenues to do that. And it seemed logical that I would use my nursing background. I'm a registered nurse, and put that to good use somewhere. So that's a brief but not so spectacular background on that. So I'm starting with this slide here because
we can see your screen.
You can't see it?
No.
Oh dear. So what do we do here? All right. Let's try again. So if I put on share screen and here, let's see here. We got it.
Oh, there you go.
There we go. Okay. Let's see. I like this picture because it shows a way this woman and I are communicating. We don't speak the same language. We're from really different cultures, but yet some spark happened between us where she approached me, and maybe it was because we were probably a similar age. I don't know, whatever it was, and she was expressing her happiness in our team being there. And I was just responding to her happiness, and it was a very nice moment for us. So I've been on 13 international assignments with MSF, and I'll just briefly say what they were. I was in, and most of them were in conflict areas or dealing directly with refugees or internally displaced persons. So I've been in Uganda, I've been in Angola, Nigeria, Kenya, 2 different assignments, South Sudan 5 times, Ethiopia, Myanmar, and the Philippines. And I was in various positions. Like I said, I'm a nurse, so I started out as a field nurse. I became a head nurse, and I was also field coordinator, field coordinator, and in charge of a project, as well as working coordination as medical coordinator. So it varied. This is a picture of the first IDP camp, which is internally displaced persons camp. I was working in Uganda, in Gulu, Uganda. This is where 90% of the people in that area of the country were forced into IDP camps because there was an ongoing conflict with the Lord's Resistance Army. And so this was my first site of that camp. And I just want to say, all the countries I've been to, for the first time, I was going to those countries. So I was meeting new cultures each time, sometimes multiple ones in these different countries. The camps were pretty horrific. They were overcrowded. People had been there for years and years. A lot of the children had never even been out of the camp at all. Things like these fires would happen on somewhat regular basis. And some of that was because small children were left at home in their huts while their parents had to go out and try to work in the field to get some extra food there. So this is just one of the examples of the trauma people have gone through that we really haven't personally experienced ourselves, but we need to be aware of the differences people have dealt with. This is also in one of the IDP camps. This group here, they're all bringing their children to be tested for malnutrition. And this woman here I spoke to, and she was expressing her fears that she would not have enough to feed her family because they weren't getting enough food in these camps here. And how I would always work with a liaison officer who was from that area, generally from the camp, if it was a camp, who could relate to the different folks there and interpret for us. These are just some of the children that they actually found me because I was probably the first white face many of them have seen as being somewhat amusing or frightening. And so we took some time to develop some rapport with them, and they would like to follow me around and that sort of thing. There are a lot of different ways we had to communicate with people. Again, generally we go into an area we don't speak their language. They don't speak my language. So we would involve interpreters, and as much as possible, we would involve local people that would be the interpreters. So they would know the folks culturally and they would know them linguistically. In a lot of areas we worked, and also you may find this too. I worked with underserved people in San Francisco, and a lot of them don't read, for instance, so we can't use written materials necessarily, as well as maybe having some other language difficulties. So what is often used are things like skits. These are local residents of this camp. There was a big domestic violence issue in the camps, so we developed programs with them and supported them. Rather than talking about it so much, they developed skits to demonstrate it. They developed music and dances that they would communicate with folks around this. And that led to a lot of young people in the camp, young women standing up and saying for the first time, this is the first time they've been able to say to anyone that they had been raped, basically. So trauma is a big thing. And again, we see that a lot in this country. People have fled violence, and we can't even begin to know generally how traumatic this was. These are children in Uganda that, like I mentioned, 90% of the people were in camps, but the other 10% were in the countryside. So every night, about 50,000 of these children would make their way into the center of town to help keep them safe from being kidnapped by the Lord's Resistance Army. So we ran a center for 4,000 of these kids, and some nights we'd have 4,000, other nights even 1,000 or more additional kids would come in. They would often walk 2 to 3 miles. You can see on their faces that they look pretty shell-shocked, and yeah, it was hard to see. So again, culturally, a lot of these kids needed some kind of counseling, but talking counseling isn't what we would do with them, but we would do picture artwork, art therapy. We would hire local people, train them if need be, but to be able to spend time with the children and do some art therapy projects with them, which helped. These are community health workers. Again, as I imagine you're all aware, it's really much easier for people to trust other people who look like themselves and are familiar with their culture. So in this case, these are all internally displaced people also. And they were the ones who really went out into the community and gave educational talks, talked to people, find out what their needs were, could report on illnesses, et cetera, and get that information back to us. They were magnificent. They did an incredible job there, and we just kind of helped them with resources and some training. So another place I went was Nigeria. We went there to respond to a meningitis outbreak, which can be a pretty fatal disease, not treated effectively. And as the outbreak itself was winding down, we did a vaccination campaign. And in Nigeria, it was extremely hot. Temperature in our car once when we were going out to some far-flung village was 150 degrees, so it was pretty amazing. So again, how we communicate with people. We couldn't put up flyers and that sort of thing, but they have town criers. And so they would have people go out to give that message to folks that there's a vaccination campaign and we want where we wanted people to come. A lot of what we had to do was develop trust with the community. And that meant for us, we had to travel to places like a day or two before. We had to find the leaders of the villages to meet with, to discuss what we wanted to do and why, and see if we got their okay. Because if we didn't have their okay, it wasn't going to work. So we tried to find the most trusted people in the villages that would support what we were doing. And in the villages themselves, one of the ways to make an impact there is to make some contact with the children. So here you can see, this is a blown up exam glove here. And these children, we had fun playing with it for quite a while. And this helped to develop some kind of trust with us so that they would follow through on the vaccinations. Often what would happen is that the village leaders would come and be the first ones to get vaccinated. And that would be, they would demonstrate that in front of the folks there, that they trusted what we were doing, they agreed with it, and this way others would follow. These kids who weren't very happy about getting a vaccination, but we would always put some kind of color on their finger to let them know that to let us know that they've been vaccinated. And some of the kids liked that coloring so much, they tried to get in line again for another vaccination to get another finger painted. Another way of trust here, we went out to these Fulani nomadic villages, and this man here was a village leader, and we had to sit down and talk with him first, again, explain what we wanted to do and why, and get his okay to call in the villagers. One of the things he did was he offered me some fresh milk from a nearby cow. It was the first time I drank milk directly from a cow, but I guess he liked that because he asked me to marry him, which I declined. I also went to Angola. Angola had a major cholera outbreak. There hadn't been cholera there for years and years and years. So it really spread tremendously through the country. So I was in the second largest city, Lubango there. We started a cholera treatment center it held 250 people at a time. Things we had to do were educate people around disinfecting, like using chlorine on people's feet, what folks could bring in, kind of food they could bring in, which would be like bananas and just the disinfecting inside. We provided everything there for them. One thing we discovered, and this is again, this cultural competency of what are people's cultural customs, how this cholera spread throughout the country in many ways was through funerals. Because culturally people would gather, a lot of people would gather close together. One of the things they would do would be touching the body, kissing the body, and by that way, cholera could spread really easily. And people can die very quickly from cholera if it's not treated. So I'm glad Dr. Fiala mentioned compassion and empathy. Again, we didn't speak the language, but you know, I just walked over to her and she held out her hand, and you know, we just sat there and kind of smiled at each other for a while, and being able to give comfort in that situation to this person was very rewarding, I think, for both of us. And even within the same area, you often are running into different cultures, people from different cultures speaking different languages. So one of the things I learned is that, well, for everybody, basically, I think the primary things, people deserve to be treated with dignity. Everybody deserves to be treated with respect, and listening to what folks have to say, what they believe, what their needs are, excuse me, is very important. So just this was a nice note. This boy here entered our treatment center with no palpable pulse. Essentially, he seemed like he was going to be dead any moment. We treated him quickly, and in 3 days, he was able to go home with his mother. Another place I went in Eldoret, another example of the type of trauma people go through that we may not be aware of if we haven't investigated or we haven't developed enough trust that they tell us. There was an incredible amount of violence after an election there, and basically primarily two different tribes were fighting each other around the election results. We all know about, you know, election results in this country too, right? Luckily, it didn't get to that point. So people had to flee their homes. They had to go and hide in the bush, they call, which is basically the forest or wherever, for weeks on end sometimes. So we would travel to different areas, see what the needs were, particularly if we noticed the clinics had been destroyed, et cetera, and reach out to the people there to see what their needs were and what we could do for them. So we developed mobile clinics. We also made a point Again, part of the trust thing is to make sure that we went to areas where people on the opposite side of the fight were residing, so that we would offer services all the way around. And that's also part of our impartiality and neutrality. Another place I was at is called the Dab Refugee Center. Dagahali is one of the refugee camps there. This is a place about 60 miles from the Somalia border, where there's constant fighting and violence going on. So thousands of people many thousands of people were in this overcrowded camp. It was so overcrowded that even as people continued to arrive, there just weren't tents for them. There weren't places to stay. This is some of the dwellings that people lived in. You can imagine that. People developed came with all sorts of trauma, from when they were fleeing Somalia. This woman was clearly burned and traumatized. This woman here, as we were, my liaison officer, myself, we would go through the camp several times a week and visit people and talk to them. By the way, he was incredible. He was a Somali Kenya. He was also a nurse, and he was just an amazing man that was able to make connections, mend fences, etc. This woman here, as we were walking by, she motioned for us to come over, and reached out to me. We sat down, and through the interpreter, she showed us her stump where her leg was blown off, her scars on her other leg filled with shrapnel, her eye that was smashed in the fighting, and several other things. And like she said, well, we asked, about her injuries and what would she need, and she said, well, I can't get to the clinic. So the reason she didn't go to the clinic wasn't that she didn't want to. She had no way of getting there. So we sent we had a donkey ambulance. We sent that and brought her to the clinic. So again, listening to people is really, really important. And also you keep your eyes open, and you see in some of the worst of times for folks, some of the greatest compassion. This was a 2-year-old who was abandoned. A young refugee woman took this child and her sibling in and took care of them. This baby here was born malnourished. His mother died in childbirth, and this older woman took it upon herself to take care of this child. And of course, we sent a nurse there every day to help with the feeding. And this was another example of the importance of treating people with respect and with and listening to what was going on with folks. This man here, he was like 70 years old, 72. They had been there, he and his family had been there about 3 months. They never received any shelter materials. He couldn't walk because of his leg. He looked malnourished to us. And anyway, and to show, he was also showing respect. I was an older woman. They had one water can. He had one of his children go and bring it to me and put their one blanket on top of it and insisted I sit there so that I would be comfortable. And that kind of grace is pretty incredible, depending on what people are going through. So anyway, we were able to do something then. We were able to listen to what they needed. They needed shelter materials. We needed to get him to the clinic for treatment, and we needed to get the kids screened for therapeutic food, which we were able to do. So a lot of what we do is looking at children. There's a lot of malnutrition in many places. In the past, kids who are severely malnourished had to stay in a hospital to be able to get treated. And if they couldn't go through the treatment there, they would usually die. And often we found that mothers, they had to have a caregiver with them, and mothers would often take off with the child after a couple of days. And it was like, how can you do that? In ours, how could you do that? So the reason they did that was because they had maybe 4 other children at home that were going to get taken care of if they didn't leave. And then we would find out sometimes the child comes back after we gave them this, it's called like ready-to-use therapeutic food. It was invented some years ago. All the NGOs are using it now, where kids can get treated for malnutrition without having to be in the hospital. So it makes a big difference, and it saves many, many thousands of lives. And this way we could tell if a child came back for their checkup after 2 weeks and they hadn't gained weight, well, then we can investigate what's going on in the family. We would often find out there's not enough food in the family. You know, they were sharing this therapeutic food, so we could try dealing with that then. But we had to hear what the issue was with the parents. This is just a picture I like. These kids are all in line themselves, waiting for the screening for malnutrition. This boy here, we ran into him in the camp. He was covered with what we found out was camel's blood, and it was a treatment that people used there, and they thought it would take the poisons out of his body. So rather than saying, "Oh well, that's not a good thing to do," we just, we asked if it was helping. We asked if they knew about our clinic services. They didn't, and let them know they were welcome to come to get our services. And we just explained that. And when we walked away, there were a group of people, they were discussing the pros and cons of the camel's blood compared to the clinic. And he did show up at the clinic later that day and received some treatment. Ethical decisions can be very difficult sometimes in the field. One of the things that is a really hard thing to deal with, I haven't had to do it myself, was in some areas, a lot of women have had what's called surgical circumcision, where they would actually, I won't go into all the details, but end up slowing up the vagina. And so if a woman came into our hospital and gave birth, that would rip open. But then it's like, we would never want to sew that back up again, it causes so many problems. But if the person insisted upon it, then it's this thing, well, what's the ethical thing to do? Because if we didn't do it and they were going to do it, they may do it in unsterile fashion, which is likely, and then causing more problems. So there are dilemmas that are not easy to decide on. This is a situation in South Sudan where, these are people trying to get food. They had all had to cross the Nile into this other part of South Sudan when there was fighting in their city when it was attacked. So again, another big traumatic situation for them. Whoops, where we go here, sorry. This is our constant care unit where we took care of these, mostly kids, but also some adults that needed to be watched 24 hours a day with whatever minimum materials we had there. This was kind of an exciting thing. We got again, this is all because people were able to trust us some and pass that on. Somebody came in the middle of the night and said, there's a woman in labor out in the road. I went out in a car with the driver and a midwife, and she gave birth to twins in the middle of the road. And we brought them back and everybody was fine afterwards. This is the tuberculosis. One of the things that happens a lot in conflict areas, it's people's, if they're even getting medication, it gets interrupted when they have to move over and over again. And then you have to start treatment from the beginning. Again, we run into folks from lots of different backgrounds. This is some of the men from a cattle camp. We went out to visit them when one of their members came in with the children who had measles. One case of measles in a camp or a condensed area means there's an epidemic. So we had to start a vaccination campaign. So there also, we went out, we met with the village leaders, and this was one of the leaders here who agreed to it. And he went and got the first shot and then had all these kids sign up. We actually found out, from looking at the kids, first look, I would have thought, well, they're probably malnourished and all that. But the truth was there were hardly any malnutrition because they drank milk a lot. And these are a bunch of displaced people, have been displaced many times. And when we were going out, seeing what was going on, we found a lot of these folks under the tree. Again, we asked them what their needs were, what we could do. A lot of things we couldn't take care of. We couldn't take care of the shelter and the water, but we could refer other agencies. But we started a mobile clinic. And so even women there who was 9 months pregnant were getting their first prenatal exam. We were focused on pregnant women and children, but then also they would bring older folks to us who were clearly in need of medical attention. And with their agreement, we would take them into our hospital and bring them back with us in a car to take them to our hospital to care for them, but only if they agree, just like here, it's consent. People have to give consent. And I just want to mention, besides the differences with the people you might be working with directly with patients, there are also cultural differences within, your coworkers. One of the hardest things for people going out in the field with MSF is working with their coworkers, because you have people from all sorts of different cultural backgrounds, and lots of times that can cause conflict. It's also very wonderful, exciting to do that, but that takes works also. So just have to be aware, because your co-workers may come from a background much different than yours, and we need to be respectful. I'm just going to play this because I love it. We went to again, the displaced people were living out in the bush, and we went and brought them a way to get water up there, and these women just spontaneously broke into song. And, and that was a song of thanks, and that's something that just happened spontaneously when people were right there. And this, thank you. If I can just, let's see if there's anything else I just wanted to be sure to talk about. I'll just mention a couple of things that were very unusual that I had to work with. At this hospital, we had set up in an emergency situation. We had one person who was doing sterilization, and he didn't show up one day. Let me see, I can get out of here. And when he finally came, it was like, where were you? And he goes, well, I couldn't come because my uncle came to visit. And said, your uncle came to visit and you couldn't come to work? He said, oh no, I can't leave while he's there. It would just be so disrespectful. So that was one of the, the cultural things that surprised me quite a bit. And there were many of them, but anyway, I think that's enough for now. But just it ends up with treat people with dignity, treat people with respect, listen to people more than you talk to people. And when you can engage people that look like them, that understand culture, to work directly with them. Okay, I think I can stop there.
Thank you so much, Donna. That was very informative and very inspirational. I had a question myself. When you're talking about consent, that's very interesting because we take it for granted, consent, right? But personally, as I've been in like emergency room or in any other room, I see a lot of older people not really understanding that what they're receiving, the type of healthcare they're receiving, and whether they want to be there or not. So I've actually personally talked to older people and they don't want to get healthcare. So how do you know, is that like healthcare in their interest, or is that extending over the bounds of consent?
Yeah. Well, in this country, we extend it there. If somebody can't give consent because they're out of it or whatever, we assume consent. If it's a matter of saving their lives. Otherwise, we explain as best we can, and we get, like I said, somebody who can speak the language and knows the culture to do that explanation. But if they don't want the care, they don't want the care. We've had people walk out of the hospital in some places where people felt you should never get a blood transfusion. They refuse it. I mean, we don't force them to do it. We just give them the best information we can and respect their decisions. In some places, it's usually women are not able to make their own decisions, and that's a really hard one where it's got to be a husband or a father or a brother that makes their decision. So you have to track them down. And so that can be really hard. And you try to get from the woman herself what she wants, but often it's deferred anyway. Occasionally we can get like a leader from the city or the village or whatever who will try to intervene on behalf of the person that needs treatment and is saying no. But still, if it's no, it's no. So it can be very difficult.
Thank you for that. If nobody has any questions, we'll move on to our student speakers, who will just give a few minutes of their own experiences volunteering here in the Central Valley or abroad, depending on who's speaking. So for our first speaker, we'll have Amber, our Publicity and Campaigns Officer. So the floor is yours, Amber.
Thank you. Hi, everyone. My name is Amber, and I'm Publicity and Campaigns Officer for Doctors Without Borders at Fresno State. So starting in October of last year, I started volunteering at the Fresno Needle Exchange Program, and this is a free clinic for injection drug users. There's a lot of services offered at the Needle Exchange Program, and the most significant being that there is it's a free clinic for them to come and talk to a couple of doctors. So it is quite an intimidating volunteering experience when you're there the first couple times, because it isn't the typical clinic. And you're not seeing typical patients. So it forces you to think about the other perspective of things that you probably don't, at least I didn't think of, and seeing life challenges, seeing like the lack of accessibility for so many things from someone else's perspective was very eye-opening and really highlighted to me how much I don't know about a lot of topics. A lot of feedback that I've heard from the patients is that volunteering and sitting and just listening to them while they're at the clinic and kind of taking the feedback they have and relaying that to the doctors, relaying that to whoever's in charge is what they appreciate the most, because they see that there's an effort being made and that they're not being treated as just a statistic, because oftentimes that is what has happened with this community. So really understanding and just listening, kind of echoing what Donna and both Dr. Fiala mentioned today, is that active listening instead of kind of forcing them to think something or forcing them to change what they're doing.
Thank you so much, Amber. And Gurneet wants to also share her experiences.
Hi, everyone. My name is Gurneet Kaur, and I'm the treasurer for the Friends of MSF chapter at Fresno State. So I recently started volunteering with a nonprofit eye exam clinic for children. And something that I've noticed is that there's a lot of Spanish-speaking patients here. So in order to be more culturally competent with that, the paperwork that we have at the clinics, it's all translated into Spanish. And there's always a Spanish-speaking volunteer to help translate. And I've actually taken a few years of Spanish, so that's something I'm able to help out with as well. So yeah, I definitely think that learning languages that are more common within your community is important, or even having staff members that know those languages. And if that's not possible, the translated documents seem to be very helpful as well to kind of help with that language barrier. And also another thing that we do to be more culturally competent is just be open and willing to listen to the patients. It feels like nowadays the hospitals and clinics are so busy that patients are often being rushed and not given enough time to talk. So at the eye clinic, we try to give patients that time, and they can see that the volunteers truly want to make a difference in their lives. So if doctors and staff everywhere show that concern, I feel like it would help the patients feel more comfortable with sharing any religious or cultural beliefs that they may have, so the doctors can help serve them better. And yeah, that was my experience with cultural competency, and thanks for being here.
Thank you, Gurneet. And I will also want to share a few of my experiences. So last September, I started volunteering at Clovis Community Emergency Room. And Dr. Bala knows this because I wrote this for my final project for his class last semester. But it was so impacted, the emergency room, that nurses didn't have more than 10 seconds to talk to their patients at once. Like they were running around, like they were so burnt out, which was crazy to see. Like, and then just a few weeks later, I don't know if you guys remember, but the SOS messages were sent out on social media for the emergency rooms here in Fresno because of how impacted they were because of COVID. So it was so impacted that nobody had time to listen to patients. So as a volunteer, of course, I had nothing to do but to listen to patients. But because I was new and I didn't know much, I was going like in the routine of just stocking up the rooms, stocking up the nurses' carts, making sure the phones are being answered, you know, just these procedural things, not actually taking care of the patients who are there in the emergency room. But I learned, of course. So after a few months, it took me a while, of course, but I started slowing down and sitting down with patients and asking them if they needed anything. And it literally only takes 15 seconds, like 15 to 20 seconds. If you just sit down and not stand up, sit down and don't say anything, just try to listen and don't interrupt them. And they'll feel comfortable to talk about what they need. And that could be anything from like, I haven't drinking anything today and it's 2 p.m. or I haven't gone to the bathroom for 4 hours. I haven't been able to reach my nurse. Like that's how crazy it was. So just me sitting down for 15 seconds in front of them or next to them, that really opened up their trust, like Donna was saying, and compassion and active listening. And they just like, it wasn't even like pouring their hearts out. They just said what they needed because they were just keeping it to themselves the whole time. So I feel like that was extremely important because nobody was taking care of them. Nobody had the time, which it's not like a personality fault. It was a institutional thing that nobody had the time to sit down and make sure that everybody's needs are being taken care of. So I just wanted to urge, because we are all students who have that extra little bit of time before we start training or whatever we end up doing. Even if you don't want to go into the healthcare field, you're definitely going to be in a situation where you can help somebody one day. So just giving that extra 15 seconds, I think, is extremely important to make sure that people's needs are being taken care of. So that's all I wanted to say. And if nobody has any questions, we're right on time for 7 p.m. and I don't want to take anybody's time any longer. So I want to give a big thank you, a big appreciation to Dr. Fiala and Donna for being here. And of course, our participants and our student chapter officers for being here and organizing this. Thank you guys so much. Today was such a lovely event and we learned so much.
Thank you. Thank you, Madame.
Yeah, and me too. And you've inspired me. It's great to hear your experiences and what you're doing.
Thank you so much.
Okay.